We'll talk about quality improvement in healthcare, residency, and beyond. Welcome everyone to today's video. Perhaps you will understand what we are going to talk about. The first and foremost is the agenda. We are talking about the QA efforts, the quality improvement efforts in healthcare. Basics of QA project, the quality improvement project, PDSA. It is akin to PDCA. Is planned to check and act as PDSA would be all about it. AIM statement, the project planning document, writing your introduction in your quality improvement paper, refreshes, probably quality improvement upcoming deadlines or residency thereby. Look what I've given you. I've given you Patient Protections and Affordable Care Act, which was the Obama healthcare that went around it. It is pay for performances, which is based on values based purchasing. Bundled payment, perhaps what we are looking into it, one lump sum for a multiple host of diseases associated with that particular diseases altogether. So yes, we are talking about pay for performances, bundle of payments. Now look, what is a quality improvement? If this particular graph can interest you, a gap exists between the quality of the care that is possible and the actual quality of care that has been delivered to a person living in US. And US is the most developed country. And think about your countries and everybody's countries, a third world country perhaps, where there is a huge gap. This gap exists. Death due to the medical errors in hospitals are higher than certain other causes in the death for USs. And death, I've just planted you and giving you the graph one at a time. With AIDS, it was 16,500. With breast cancer, it is approximately 43,000. With auto accident, it is approximately a shade above breast cancer, is 43,500 approximate. Medical errors, you look into it, it's a whooping 44,000 deaths, and that is what we need to improvise. So, quality improvement, a gap. If you want to go around it, see, look at what the mortality amenable acts that has gone right from what has happened. See, death per thousands population, 100,000 populations. In terms of France, which is the least, approximately 1977, it was 76. Right now, it is 60. Or the way you want to go around it, and look how every countries has improved altogether, and that is what we wanted to think about it. I have given you this particular slide. I would request you to pause it and probably see the improvement in the cycle, and if possible compare, try to find certain data about your own country from where you are actually going on per 100,000, how much deaths have been done, amenable healthcare, mortality with respect to the healthcare professionals, healthcare interventions, if I may say so. If it is not decreasing, probably the medical infrastructure is not on the right path. Look at US, it's 115 and 110, which is more or less the same thing that has left out there at that point of time. So why quality improvement? We need to talk about the quality improvement as in uh, the deficit that needs to go about it. Look over the quality improvement aspects of US thereby. So infant mortality in US per thousand live bird has is double of the other leading nations. So other leading in Japan it is approximately 3, in US it is almost 7, touching 7 per thousand live birds. There are mortality. The infant which basically is not able to survive beyond 3 months of living. Average spending per capita in US, you look, is such high, so high. Germany, it's very less, and still the dismal performance is thereby. Due to the seriousness of this shortcoming, there's an increasing importance of the physician and the resident to learn the modern quality improvement techniques and tool. Now, what are we looking into it? We are talking every system is perfectly designed to get the result it gets. This means the US healthcare system is definitely designed to achieve its objective, achieve 44,000 to 98,000 inpatients death per year due to medical errors, have twice the infant mortality rates of other nations, do all that for twice the cost per person of industrialized countries. I've already shown you the graphs. You can respond in one or three ways. Either you admit it, or you ignore it, or you blame someone else. So you need to understand what is to be done and how do you want to do it. The only way to get a different result is to change the system. Institute of Medical Medicine reports (IMR) to err is human. Building a safer healthcare, putting the spotlight on tens and thousands of Americans die each year from medical errors. Effectively put the issues of patient safety, quality on the radar of the screen of the public and private policy makers, as the case might be. 2001 crossing the quality chasm, a health new health system for 21st century. Describe broader quality issues, define six aims for care delivery and redesign. The Institute of Medicines proposed six specific aims for the improvement. That is, the healthcare should be safe, which means there will be avoiding injuries from care, effective, which means avoiding underuse or overuse of services. It should be patient centered, as in providing respectful, responsive, and individualized care. It should be timely, reducing waits and harmful delay in care as on when on basis. It should be efficient, avoiding waste of equipment, waste of supplies, waste of ideas, and waste of energies. And the last one is equitable, providing equal care regardless of the personal characteristics that happen. So how do we cope? We can do about the PDSA or PDCA, plan, do, check, and act in this of essay study, plan, do, study, and act step. Five-step process of quality improvement. Select the opportunity for the improvement. Study the current situation. Analyze the causes, root cause, and develop a theory for improvement thereby. And once you have developed a theory, who is going to implement the changes thereby? So, model for improvement is to aim, change, and measure. Aim is what you are trying to accomplish. Change is what can we make that will result in improvement, and measure how will we know that the change has an improved. This is what implementation is all about it. After you have done it, study the result and probably uh, establish a future plan in case it's meeting your criteria or it is unable to meet your criteria. So yes, PDSA is all that we're looking into out here. Present situations and ideal future situation is what the idea is all about. When selecting a QI topic, quality improvement topic, go for the low hanging fruit. Ensure organizational support from the bottom ups altogether. Low hanging fruit in the endocrine system, no show rate. Endocrine patients, a healthy lifestyle patient, what is happening? In case there are people suffering from disease, they are not aware of what they are just deferring their medical intervention because of cost, because of the price, because of other issues, as in the lifestyle and so on and so forth. Medication compliances in adolescents with diabetes, diabetes school forms, motivation to make lifestyle changes in healthy lifestyle patients. Remember, we need to be safe at all time, come what may. So, the PDSA, the Plan to Study Act cycle, let us go into the five-step process of selecting the opportunities and model for improvement altogether. Selecting the opportunity for improvement is no-show rate in the pediatric endocrine system. Studying the current situation is defining what can be improved in this particular area and what is necessary. Health risk of the patient who doesn't show, perhaps. Health risk of the patient seeking an appointment but unable to book an appointment. Poor staff utilization. Loss of multiple stream of revenue. Collect and review baseline data of your problem area. Now, this is what you have to go around here. Track the following for 1 month. Total number of patient appointment to be scheduled around a total number of patient actually seen. The no-show rate, if you see, is a whooping 35%, more than one third what is looking into it. So healthcare, now we'll talk about the planning stage. Now, how it happens, analyze the causes altogether, determine the factor contributing to the no-show in your population, the reasons given of are the cost, are the transportation, are coordination, logistic, or couldn't get off work, forgot appointment, felt better, and felt too bad to leave the home. Describe the current process for the patient appointment reminders. Automate phone calls to primary phone or get an SMS, short messaging service of estimated medical interventions 48 to 78 hours before appointment. Let us understand the developing a theory for improvement. Developing a theory for improvement is what we should be looking at, what should be done, and select a team who can actually go around it. Now let us go with the aim. Aim is a good specific measurable, addresses a point for whom, for what system of the pleasures would be all about it, how good it is, by when, and we'll reduce the patient appointment no-show rate from pediatric endocrine system from 35%, that's one third, to 20%, that's one fifth, by some deadline. Then we should be talking about the measure part of it. Let us go for theories of the changes, process for formulating the ideas of changes, critical thinking about current system, flowchart of the current process, analyze the data on the current system, benchmarking, comparing your own process to the best practices thereby. We are talking about taking the patient's perspective also, not only the medical perspective, but also the patient perspective, asking the patient caregiver for ideas using technology, text messaging, social media appointment, offline secretary to make phone calls to a patient caregiver 24 hours before appointment. Did I say we need to measure the things? Yes, aim, measure, and then probably change. What do we measure as qualitative data, subjective, quantitative data as an objective. The three main types of outcomes, the outcome measures, process measures, and the balancing measure. I recount, recall outcome measures, process measures, and balancing measures. In outcome measures, are you reaching your ultimate goals? No show rate in pediatric endocrine clinic, how it has improved or decreased. Process measures are the part steps in the system performed as planned. What percentage of patients are receiving reminder phone call from secretary? Balancing measures are the changes designed to improve one part of the system, causing new problems in other part of the system. Are the secretaries unable to get their work done because of the time spent calling patient altogether? So identify a QI mentor, quality improvement mentors. Be sure to include members familiar with different parts of the process that you are trying to improve. Endocrine team, myself as the project leaders, as the case might be, Dr. Whitney Brown. Maybe I'm just giving an example as a division director, endocrine clinic secretary. There should be, if we look into it. So this is a QI project planning document, and it's a sample document. Need not be a sacrosanct one. You can adapt it towards your taste, requirement, environment, probably country specific requirement if there are. Now talking about the resident name, doctor's name, the team members, myself, faculty members, and the other team member. Aim, what are you trying to accomplish? Measure, how will you change the improvement, outcome measures, process measures, and balancing measures. And changes, what changes will result in improvement. And that is what we need to talk around here. So if you want to go around Lisa, resident name, I can be Lisa names, the patient name, the reduced no-show rates. We can see everything that comes around here. Secretary to make a phone call to patients every 24 hours. Now always start small. Present situation, a PDSA, first PDSA plan to study act. We talk about it, not only my patient, not only the three endocrine providers, morning clinic, let's say a particular date that can be given. There are 10 patients, increasing in scale, increasing in scope, and we are looking the ideal features out here. It is from the present situation to the ideal features out here. QA versus research. What is QA research? Research is from hypothesis, take it until the bitter end. One last test, the t test, chi-square test, and the p value, the pi value, as the case might be. In quality improvement, it is all about forming a hypothesis, adjust through multiple PDSA, plan, do study, act, cycle to work out the kinks, sequential test, run charts, and Shewhart charts. In QI, the goal is to improve the condition that exists, not merely to describe what is happening. And to do that, you need to be able to modify your assumption, retest your theories, and on what you learn in the course of your test per se. So that is where you need to go about stealing shamelessly as far as quality improvement is all about it. Remember, PDSA, we have been speaking about the selecting the opportunities, let's say hyperglycemia and diabetics after transition from insulin GTT or SC injection per se, study the current situation, define whether the improvement in area is necessary or has it been done. Do you recommend a prolonged hospital stay if there are frequent BG checks that needs to be done, frequent corrective insulin injection that needs to be implemented? adding stress, anxiety for the child or the caregiver. Perhaps study the current situation, current transition protocol. Half dose of Lantus given at breakfast, insulin, GT-TDC injections, half dose of Lantus given at the bedtime, full Lantus given at the following night at the bedtime. Collect and review your baseline data in your problem area. Track the following for 6 months. Average BG level for each patient as on when on basis. How do you go across with it? In 4 to 6 hours before insulin gets injected, in 12 hours after the full dose gets injected altogether. So you need to study all the injections of the insulin as to treating your blood sugar levels. So the third step is analyze the causes. What do we go determine the factors of hypoglycemia, the blood sugar levels? Was the insulin did it turned off too early? RCHO been counted? These are the medical intervention that we need to go around it. The patient, the caregiver seeking food, drink in their room, or stealing group food or drinking in the room. Are insulin doses being calculated correctly? Does the current transition protocol give enough insulin? Now you coming to a theory, perhaps what all the medication that needs to be administered. Half dose of Lantus transition protocol provides to be the basal insulin. Will give a full dose. Means you are increasing your doses. Selecting your team is yourself or myself, Dr. Whitney, anybody who goes about it. Now we come into the QI write up, quality improvement write up as an introduction. Give a background knowledge. Provide a brief non-selective summary of the current knowledge of the problem being addressed to and the characteristics of the organization in which it occurs. Local problem describe the nature and severity of the local self problems or system dysfunction that will be addressed. Intended improvement describe the specific aim of proposed interventions, changes, improvement in care, focuses. Specific who champions, supporters, what events trigger the decision to make a changes. Study questions, specific study, the aim statement of the project, detail precisely everything, all your question, all your secondary question that needs to be answered and intervention needs to be designed. Remember, we know what good health is. That is not a problem. The challenge is to close that gap between what we know, what to be good care, and what the care that the people actually receive. With these words, I wind up today's presentation. Thank you for watching.